Hello, thank you for joining us today for the latest webinar in the Targeted Learning webinar series funded by the FDA. Today's webinar is developing a targeted learning-based statistical analysis plan and is presented by me, Susan Gruber. I am a biostatistician and computer scientist and the founder of Putnam Data Sciences, a statistical consulting firm. And it's been my privilege to be heading up this targeted learning project for the FDA. We have many FDA collaborators and also Rachel Phillips and Mark von der Laan at UC Berkeley. And so today's presentation reflects the work of all of us, and of course, any mistakes are mine. So to talk to you today about a targeted learning SAP, it seems to me that the first question is why are we even interested in a targeted learning perspective? We already have the ICH harmonized guideline that provides guidance on how to construct a statistical estimates and carry out analyses. I've extracted some key phrases from the ICH-E9 Revision 1 guideline that I think are important for us to have in mind today. The guideline tells us to construct the estimand corresponding to a clinical question of interest. The description of the estimand should reflect the clinical question of interest in respect of intercurrent events. The statistical analysis should be aligned to the estimand, and sensitivity analyses should explore the robustness of conclusions from the main analysis. And I hope to show you today how targeted learning can help to achieve these goals. So let's review the targeted learning roadmap. I like to start with a step 0, a well-defined question. And from there, we construct a realistic statistical model M and causal quantity of interest, psi causal. And this is all in terms of some counterfactual theoretical ideal, a model that captures the known bounds on the problem, and a causal quantity of interest in terms of counterfactuals. But of course, we have to estimate this thing from observed data, and so we also need to define a corresponding statistical estimand in the observed data that we'll call psi observed. Step 3 is to actually estimate this from data in a way that respects the bounds on the problem, provides statistical inference, and finally, draw a substantive conclusion that is based both on the effect, but also on the strength of the evidence that we might assess through these sensitivity analyses. So you can see that this dovetails very nicely with the ICH guidelines on the previous slide. We're going to ground today's talk in a fictitious example of a randomized trial for a drug to treat migraine and headache pain. And we'll go over the 5 elements of a statistical estimand laid out in the ICH guideline: the population, treatment, outcome variable, summary measure, and intercurrent events. And recall that these are events that occur after treatment initiation and alter the treatment strategy or the outcome of interest. We're also going to be informed by the targeted learning roadmap. And to my mind, this brings 3 advantages with it. First is that the causal quantity of interest is defined separately from the choice of estimator. You're not automatically bound to estimating something that's a coefficient in a particular parametric model. A second benefit is that this targeted learning perspective is going to provide clarity on how to represent and adjust for intercurrent events appropriately. And finally, since we recommend estimation using TMLE and SuperLearner, I want to just assure you that this is completely pre-specified and reproducible. Unlike other machine learning approaches, and causal inference will also provide valid inference, and yet will remain data adaptive. So let's start off by completely specifying the background. So let's start off by grounding this in our example. The population of interest are adults aged 18 to 65 years who have had a consultation for migraine or chronic headache within the past 24 months and experienced at least 2 headaches per month in the past 6 months. And then on top of that, we have some exclusion criteria. Now for our precise definition of treatment, we say that there are going to be a comparison of the study drug A with an active comparator drug B. Both of these are 500 milligram tablets that will be taken once daily. There'll be a 90-day supply dispensed at baseline randomization. And then every 90 days at an in-person visit, the next 90-day supply will be dispensed again. And you'll notice that I have a 1 on the tablet representing the study drug A and a 0 on the comparator drug B tablet. And that's because in subsequent slides, we'll have a treatment indicator. And when A equals 1, that indicates the study drug, and A equals 0 indicates treatment with the comparator drug. All right, so we have a well-defined population. We understand what the treatment is. The outcome variable of interest is something called the mean weekly headache score, 12 months after randomization. So what the mean weekly headache score is, there's a daily headache score that's on a scale of 0 to 10. Over 7 days, then that headache score is between, the sum of it is between 0 and 70. And then we'll take the average of the weekly headache scores over 4 weeks. So mean weekly headache score is the average of weekly headache scores averaged over 4 weeks. That's our outcome variable. And the contrast, the causal contrast we're interested in is the average additive treatment effect of one group versus the other. So the average additive treatment effect of treatment versus with study drug A versus comparator drug B. And for intercurrent events, we know, like, we can foresee that there'll probably be some treatment noncompliance. We'll probably have some incomplete capture of the outcome. And we also will have outright loss to follow-up. People will drop out. And then there may be some intercurrent events that I don't have on this list that you can foresee that I would add to the list. And then, of course, there's going to be ones we can't foresee at all, like a global pandemic that could really mess things up. So I'm not going to say that a targeted learning perspective is going to help us foresee things we can't foresee, but it will help us kind of formalize and plan and appropriately handle the intercurrent events that we can foresee. So on our roadmap, we now have a well-defined question, and it was these precise specifications that we saw on the previous slide. Now we're up to the next step. We're going to specify a realistic statistical model, M. And what that means is it's a collection of probability distributions of the data. And we don't have to include every possible probability distribution in the world. The ones that we're interested are the ones that respect the bounds on the problem. For example, treatment is binary. The mean weekly headache score is bounded between 0 and 70. And our causal quantity of interest that I wrote as psi causal, we're going to define that in terms of counterfactuals instead of, as I said before, not just a coefficient in the model. All right, so if in your mind, you're probably thinking that we would just write it something like this, that our counterfactual causal contrast of interest is the expected value of the outcome if everybody were treated to using the study drug, minus the expected value of the outcome if everybody were instead given the comparator drug. So that's what that means. But that's sort of a point treatment view of what's going on, and it ignores the likely intercurrent events. And I want to argue that since we know some of this, we'll try to avoid them, but we know that some of them are likely to occur. And so we're going to formalize the representation of psi causal with respect to the process, the entire process that gives rise to the data. And that's going to be more longitudinal in nature. And that exactly is what the ICH guidelines tell us to do. They say it should reflect the description of demands, the clinical question of interest in respect of intercurrent events. So I'd say this doesn't, and what we're going to go over next does. So here's how we collect the data. People are randomized at baseline to get the treatment, either study drug or comparator. And we're going to collect some covariates on them, and we'll call that whole collection L0. And here's an example of what we might collect: age, sex, the mean weekly headache score in the 4 weeks leading up to randomization. There's an event and then 4 weeks, and we randomize people who have shown that they can do the record keeping. the headache type that they have, severity, chronicity is how long they've had it. And maybe you can think of some other covariates we'll collect. Those are all L0 collected at baseline. Then we move on, and 90 days later, it's time for an in-person meeting, and they'll get their next supply of drugs. So some people are not even going to show up. They drop out. They drop out at 90 days, and we'll call that a potential censoring event. If they don't drop out, but they show up, then we can collect some more information on them. And the information will be maybe the mean weekly headache score in the past 4 weeks, and also the number of headache-related health encounters they've had, say, in the past 90 days, some side effects they might be feeling, fatigue, nausea, trouble concentrating. We'll give them, at this time, we'll give them the next 90 days worth of their study drug or comparator drug. And also what's not on the slide that Hannah pointed out to me was, for these people who didn't show up, we might, try to contact them to get them to come in and have a little grace period, or we'll at least see if we can find out the reason that they were dropped out. So try to capture here the reason for dropout. Then we continue, and the very same thing happens 90 days later. They either show up or they don't. If they show up, then we'll capture the same information and we'll give them the next 90-day supply of drugs. It happens again. And each of these time points, L0, L1, L2, L3, those are sort of the time points that we're collecting the covariate information over. And then finally, at the end of follow-up, if they show up at all, then we can collect finally their outcome, the mean weekly headache score over the past 4 weeks. So that's the way that the data are generated. And all along, we've at these red nodes, we've illustrated that there's a potential for loss to follow up. And not only that, at the blue nodes, the A2, 4, and 6, somebody might show up in the clinic and say, I'm not taking this drug anymore. I will keep coming to my appointments, but I feel terrible on it and I won't do it anymore. So they may be non-compliant. And we capture that also with A4. A4 and A2, 4, and 6, those aren't necessarily the treatment they've been assigned to at baseline. It's the treatment that they actually followed. It's indicators, were you on your study drug, your comparator drug or not, your assigned treatment or not. Okay. So now we can write our desired causal parameter still in terms of counterfactuals, but now in terms of the causal contrast we're really, really interested in. And so this whole big first part here is the outcome in the, in the counterfactual setting that you are treated with the study drug at all of the time points and that you remain uncensored at every time point. And we're interested in so that's one counterfactual outcome. And then the other counterfactual outcome is that you're treated with the comparator drug at all the time points and you remain uncensored. And so just a kind of a more shorthand way of writing that, we can also say it's, the outcome observed under this series of settings, this intervention history where we intervene at each of these possible points and say, take the drug I assign you, show up, take the drug I assign you, show up, take the drug I assign you, show up. So this is taking the study drug at every opportunity and remaining uncensored. And this is take the comparator drug at every opportunity and remain uncensored. Those are our counterfactual outcomes of interest. Okay, so now that's all well and good, but we don't have counterfactual outcome. We just have observed data. So we have to estimate something. What parameter are we estimating in the observed data? And as you know from earlier, exposure in this series, we're going to have some identifying assumptions that link the observed, some parameter of the observed data distribution to the causal parameter. All right, so the data that we get in the real world is, say we have n observations, they're IID, And each one looks like this. You know, we have a covariate vector at baseline, then we have what you actually took at baseline, whether you were lost to follow-up or not, your covariate vector at time 1, what you actually were prescribed, sorry, if you, what you were prescribed, what you took, I mean, and then if you remain uncensored, etc., at all the time points. And this L4 contains the outcome value Y. And we're interested in something that I'm writing as sort of a marginal mean if you follow the regimen for the study drug, minus the marginal mean if you follow the regimen for the comparator drug, but the marginal mean over the entire population. And so we talked about this in an earlier webinar. I don't want to go over it. This might jog your memory, and if not, we have the webinars on YouTube. They may be in some internal FDA website. So if you look up the causal inference of longitudinal exposures by Marie Schnitzer, then she covers this. And I'm not going to do it now because it's there for you. And obviously it's in papers and publications and other talks as well. Okay. So we have to now consider the causal assumptions that would link the parameter we can estimate, the statistical parameter in the observed data, to the causal parameter of interest. And the first one of these is the consistency assumption, which states that the observed outcome under the sequential treatment regime, A bar T refers to sort of the whole sequence of settings for those different nodes. So the consistency assumption says that if we have a series and it equals the one of interest, then that's going to equal the counterfactual outcome under that interest. So what I mean is, it's just better if I just go to the example. Consider some subject I who is randomized to the study drug A. So their regime of interest is that their history from time 0 to node 0 through 7 is all ones because they're randomized to the study drug. But if what actually happens is that person takes the study drug, shows up, takes the study drug, shows up, refuses the study drug, shows up, refuses the study drug, shows up, then their observed treatment history looks like this. This is not our regime of interest. Therefore, even though we've measured an outcome for them, we have not measured their counterfactual outcome under the regime of interest in a per protocol analysis. I'm talking about the true causal effect here. So this, for me, is the clearest way to say that intercurrent events have disrupted, and the intercurrent event that's disrupted it is refusing to treatment, the assigned treatment. And so this outcome does not match the counterfactual outcome of interest. And when we get to the estimation part, I'll talk about what we do about this. But if you just ignore this fact and you put this outcome in as the outcome and pretend that it's the outcome that would have been observed under this, then you're not answering the right question. You're getting a biased answer. Now I'll just back off that a little bit and say you might be interested in the ITT analysis. You might be interested in the question of what happens if I start you or prescribe the study drug. And that's a valid question too, but it's not this one that we're considering. For the purpose of a per protocol analysis, it's important to notice that this is a violation of the consistency assumption, and we can deal with it in the estimation phase, but we can't deal with it if we ignore it. We have to actually state that this is going to happen and this is what we're going to do about it. Okay. So, I said all this. So we want to apply thinking about the consistency assumption because it gives us a clear representation of why it's problematic for a per protocol analysis and why, from that causal perspective, the outcome is missing. Even though it's written down, it's not there. But if it's intention to treat, then we don't have a problem because intention to treat is agnostic about what happens after baseline. Okay, then we have a second causal assumption that we have to think about, and that's the positivity assumption that basically just guarantees a sufficient support in the data for estimating the parameter of interest without having to impose any other additional assumptions or smoothing or anything. So the way that this works is, you're used to thinking about the propensity score, and that has to be bounded away from 0 and 1, because you want people to be able to either be treated and untreated, have the probability to just not be 0, because then that would be a true violation. So we actually have to do that at every time point. And so what you do is you estimate the probabilities of getting the treatment given the past, and you estimate the probabilities of being censored given the past. And you need to take the cumulative products of those. And the cumulative product at each time point has to be bounded away from 0 and 1. So if you ever are reading the literature or in other webinars, we sometimes refer to these G components of the likelihood. And we denote them, these products, like, if T is 3, then we might have, the product of the first 0, 1, 2, and 3 of those components. And at every time point, we have to be bounded away from 0 and 1. All right, so randomization guarantees that positivity holds at T equals 0, so we don't have to worry about that. However, after T's, at later time points, if you have any treatment noncompliance or you have loss to follow-up, then it's not really guaranteed anymore. If you start out with, say, 10 men and 10 women, and then at time point 2, all the women drop out, then suddenly positivity doesn't hold anymore. So you can investigate this by looking at propensity score and miscellaneous probability diagnostics. And you have to do it at every time point. You can't just do it at baseline. The third causal assumption is coarsening at random, or you might think of it as conditional exchangeability, or informally as no unmeasured confounders. And so again, we know this is going to hold at baseline because randomization, let's say, is just a coin flip. But you don't really know if intercurrent events are a function of baseline covariates only. If side effects on treatment itself lead people to drop out or to be non-compliant, then if you've measured everything, you're in good shape. But if it happens because of something you haven't measured and haven't recorded, then you're in a situation where there'll be residual bias, and there's nothing you can do about it, except for, we'll talk later about how sensitivity analyses can help you think through how much problem that might be causing. And so the best thing is to not have unmeasured confounders. And so it's prudent to record potential time-varying confounders and the reason for dropout or noncompliance in addition to the baseline covariates that you measure. That's always a good idea, because hopefully then you won't have unmeasured confounders at all. And just as a reminder, when you have time varying confounding, it's not as simple as putting that variable in the model versus leaving it out. If you put it in, then you might adjust away part of the treatment effect. If you leave it out, then you're ignoring it and you've got unmeasured bias due to unmeasured confounders. But TMLE is able to handle this. So statistically, mathematically, get the correct answer and not. Okay, I'll stop there. All right. So we have now gone through the first 3 steps of the roadmap, and we're up to estimating this parameter, the psi observed from data, in a way that respects M. And let's see. We've had a lot of talks about how TMLE works and superlearning works, and so I'm not going to talk about that now. I want to talk about the SAP. If you're going to be writing about how you're going to estimate the parameter using TMLE and superlearner, then there's a lot that goes in there. And so one thing that goes in there, and this is not restricted to just a target learning based SAP, but you should proactively plan to avoid or mitigate the effects of intercurrent events. And you know that already. I just thought it was important enough to put in here because, statistics is, the closer you can come to having, that pristine RCT data, the better. And we're saying, as you deviate from that, then I say TMLE and Superlearner are going to give you a lot of protection, a lot of latitude. But the less you deviate from that, the more sure you always are going to feel about it. So the usual strategies apply here too. You might devise a composite outcome. You might make sure that you remind people to show up for their visits. You might try make an effort to have them to continue to be followed up even after non-adherence, record the reason for non-compliance, etc. So definitely do that, and you'll be in better shape with any estimator, including TMLE and Superlearning. But we're also going to have to document how we're going to handle missing data that might arise, and we'll do that on the next slide. And then also, we've devised some checklists so you can pre-specify every single aspect of TMLE and Superlearning to make sure that you've got something that's robust, reliable, reproducible, and completely documented in advance. You can do that and still be data adaptive. All right, missing covariates. For each covariate where there's a missing value, we're going to create a binary indicator that's 1 if it's observed and 0 if it's missing. And the reason to do that is because the very pattern of missingness might be informative. And we'll create the binary missingness indicator and just add it to the data set as another covariate, as another thing to potentially use to, in the analysis. But the value itself, the missing value, you can't just set it to NA or something because the math won't work, or a dot in SAS, because we don't want to drop these observations. So what we do instead is we set them to some innocuous value. So like say 0, or you might choose the mean if the variable is continuous, or the mode if it's binary or categorical. And the point is that that way we're not doing any kind of parametric imputation or anything that's introducing any kind of bias. We're just setting it, and then we have that missingness indicator to sort of like sop up any of the pattern that goes with the fact that that value is set to some constant. Okay, missing outcomes are handled differently. And of course, you're going to discuss with clinicians what missing outcomes really means. And, if there's some substitute or something that lets you have a valid value, that's great. Or if you know that if that outcome isn't there, it has a certain meaning, then absolutely. I'm not trying to override clinical expertise. But I'm saying, once you've done all that, there still might be some outcomes that are just missing. The person didn't show up for that last meeting. They didn't keep those last records on the weekly headache score. So we've observed them for so long, and now we don't have the outcome. So we have to legitimately set them to missing, but we don't drop them from the analysis. We don't just do a complete case analysis. We just set them to missing, but we leave them there. And that leaves the population intact. We still have the same target population. And when we do the marginalizing, the averaging over everybody, we're averaging over everybody that we started out with. We're not averaging over some subset who is a complete case and complete adherence. Okay. Also, we saw those intercurrent events where people just weren't following the regime of interest. And so we also set their outcomes to missing because of that consistency assumption violation. So we don't want to use the outcome that we observe for them because it's not the one that corresponds to their regime of interest, again, in a per protocol analysis. So we set it to missing. And in the estimation procedure, we'll deal with that appropriately to get an unbiased estimate of our causal effect, or at least of our parameter in the observed data. Okay. So these TMLE and Superlearner specifications can get lengthy, and there's a lot that goes into them. And so we made some checklists, and I've included 3 of them in here. So the first checklist is about just reproducibility. So if I said, here's how I do the analysis, and here's some of the basic things you need to know, that's in the reproducibility checklist. And then if you're going to do a longitudinal analysis, say using the LTMLE package, then that's got some, besides the data that you need to pass in, You also have to set what we call tuning parameters that control how the analysis is carried out. If you're doing a point treatment analysis, you do the same sort of thing, but for the TMLE package. And then if you're using super learning for the outcome, there's specifications for that. You could have separate specifications for the propensity score and even other specifications for the missingness and censoring probabilities, modeling those things. And so a separate checklist for each one makes it so you can't forget to write everything down. So I'll just show you an example of what those look like. So here's the reproducibility checklist. There's randomness involved in super learning in particular. So setting a random seed at the start of the analysis is necessary if you want to be able to reproduce it. So it doesn't matter what the random seed is, but you have to set something. So I wrote it will be set to 10, but it's arbitrary. Then we need names and version numbers of all the software that's going to be used. And so I wrote those here with a brief description. And I picked these because these are the defaults that we use in the TMLE package. They're not bad. You could add more. I don't say that these are the right ones to use for everything. And a larger list is fine. If you were going to be doing a longitudinal data analysis, that's like I just proposed for this fictional study, then you might be using the LTMLE, longitudinal TMLE package. And in this case, there's some things that you can pass into it. So Q form, that's the shorthand if you wanted to use a parametric regression model for the outcome. There is no default setting. I mean, the default setting is not to use it. And I would not encourage using it, but it's there as an option. Instead, there's the default library for using superlearner to estimate it is actually just linear or logistic regression. And so that's the default, but I wouldn't recommend that. That's the default just because it just defaults to just generalized linear modeling, but there's no reason to do that. And so I have a comment in here to say, absolutely add learners to construct a more robust library. So here I've just shown that we'll use BART and Lasso, and they're not parts of the defaults. So I don't need to go through every row of this thing, but I'm just saying that every row of this should be documented if you want to be able to pre-specify completely the analysis and be able to just run it over and over on any machine, any person, use these settings, you'll get the same result. Okay, the next checklist is how you might use superlearning for an outcome regression. And it's just got different arguments, different settings, different defaults, different things to talk about. And it's all there. And then we would also have similar checklists for the propensity score modeling and the censoring probabilities. And the probabilities for all of those A nodes, or what we also call the intervention nodes. So there's too much. I can't tell you, in today, I can't tell you how to exactly fill all those things out. So next month, the webinar is going to discuss practical considerations for specifying a superlearner. And that will take you a long way into knowing whether the choices and what was documented is good or not good. And the announcement will be coming out next week. We're also going to distribute a sample annotated SAP that describes the analyses for this hypothetical study and includes all the checklists with sample entries. And finally, as part of this BAA, we're going to have a short course. And so a lot of the more specific questions that you might really need to know if you're reviewing one of these proposals will be addressed in these forums, and you should take advantage of those. So here we are in the roadmap. We're up to statistical inference because now we have our estimate and we want to put confidence interval bounds on that and p-values. So we have several methods that are backed by theory. And in the first two, there's influence curve-based inference. That's in both the TMLE and the LTMLE packages. The LTMLE package also offers something, they call it TMLE, but it's a robust targeted variance estimate. And that's a little more robust than the influence curve based estimates. And finally, you could do bootstrap resampling. And any of those will work. Bootstrap resampling is pretty computationally expensive. And so it's nice to be able to just rely on the analytic variance estimates that are just returned by the software automatically. Then finally, the substantive conclusion should be supported by sensitivity analyses. And you can do the sensitivity analyses that you feel are appropriate. Obviously, keep doing those if you want to look at a complete case analysis and see what the effect is there. If you want to look at, say, if you had done it from a point treatment, feel free to do point treatment analyses and ignore the longitudinal nature, just out of curiosity to just build up a picture. That's all well and good. And it's even appropriate if you don't have any noncompliance and you have 5% loss to follow up. Then all this longitudinal stuff, a lot of it is going to just mathematically reduce to a point treatment problem anyway. So I'm not saying don't do those sensitivity analyses, but I will say that there's one thing that we really suggest you do in addition to those. And that's a non-parametric sensitivity analysis. I should have put a citation on here. I'll do that before I post the slides to a 2013 paper by Yvonne Diaz and Mark Vondelon. They talk about something called the causal bias, the gap between the estimate and the truth. And this gap is going to be due to some violation of one or more of the causal assumptions. And the idea is that you don't know what this unknown amount of causal bias is. But you can think, what would the impact be? Suppose it was large, suppose it was small. Then how would the estimate change? How would the p-value change? And how would my bounds on my confidence interval change in response to smaller amounts of causal bias, a residual bias, because we had a positivity violation, because we ignored that consistency assumption, or most likely in these settings that are in these randomized trials, because of maybe unmeasured confounding due to time varying covariates that you didn't capture completely. So that's the kind of thing that you need to use domain expertise to think about. But the plot I'm going to show on the next page can at least help you think it through. So this looks complicated, but let me tell you what it is. We had RCT data that actually was about using acupuncture for migraines, so it sort of inspired our hypothetical example. In this RCT, there were about 400 patients, and 25% of them had the outcomes they were actually lost to follow-up. So it was an ITT analysis, so it wasn't about per protocol violations. It was that they literally didn't have the response measured for about 25% of the patients. So the unadjusted estimate in the complete cases is shown here in this very light gray line. And after we did the analysis using TMLE, we got this as a point estimate. And this is the confidence interval, the 95% confidence interval from our longitudinal analysis. Okay, so our point estimate was negative 5.42. The unadjusted estimate in the complete cases was negative 6.1. So the difference, when we did the best we could to adjust for the bias using, in the unadjusted estimate, the best we did was we moved this estimate a little closer to the null, and by 0.68. So what I did on this plot was I said, well, suppose we have residual causal bias, and it was 5 times larger than that 0.68, than the actual bias that we were able to adjust for. If it was 5 times larger, and the bias had moved us towards the null, so the actual estimate was further away from the null, then our point estimate would actually have been over here, like around -9. And the confidence intervals are between -6 and -11 or so. So that means, the drug actually reduces headache problems even more than we thought due to this hypothetical assumed level of, in mostly biased due to, let's say, unmeasured confounders in this case. If it was 5 times in this direction, then the treatment effect is even more. Treatment's even more effective at reducing migraines and headaches. Well, that's if it was 5 times as large in that direction. But what if it was only 1 time as large? What if it was 0.68? We managed to only reduce the bias by half from the unadjusted estimate. Then we still have a point estimate that's like very close to it'd be the unadjusted estimate, and the confidence intervals are still, well below the null of 0. What if it was in the other direction? What if it was 3 times as large and it had made us think that the treatment effect was real, but it was actually a lot less real than we thought? Well, actually, we still would have treatment that reduced the headache score by around, to around 4. The difference would be about 4, and the confidence intervals are still well below the null. And we'd have to have unmeasured confounding that had been in the direction away from the null 4.5 to 5 times as large as what we were able to adjust for in the complete analysis in order to finally get that the treatment had no effect. So when you see a plot like this, you need some experts to sit and think hard about the problem, and given everything collected, and this was a longitudinal analysis that adjusted for the intermediate covariates that were collected as well. Do you really think that there was some major large intermediate covariate that could have been responsible, or maybe even the unmeasured baseline covariate, except we have baseline randomization, which really helps. So do you really think there could have been something this larger than everything that we adjusted for? If so, then this is plausible. And if not, if you rack your brains and you're an expert and you say, I just don't think that anything exists like that, then I think that this kind of plot gives you a lot of confidence that you've got a treatment effect that's favors the study drug, and it's a true effect and not just due to residual bias or chance. So that's what this non-parametric sensitivity analysis can do for you. So that is all the steps of the roadmap and how it impacted the production of the SAP. What I want to leave you with, that was a lot, we'll have some time for questions. What I want to leave you with, though, is that if this is an area you're interested in, then I want to recommend this paper. There's the ASA biopharmaceutical section put together a working group, the Real World Evidence Scientific Working Group. And this paper is led by Martin Ho and others. And it discusses this whole thing about real world evidence. It doesn't talk about SAPs. I don't think it mentions them. But it discusses real world evidence and how to think about it from this perspective. And so if you're interested in it, I totally recommend this paper to you. And it's really clear and comprehensive and directed to biopharmaceutical section members. So it should be of interest. All right, I think what I'll do is I'll stop there and see if there's any questions. Okay, we've got one. Does the causal parameter assume every subject can tolerate and have a potential outcome under both drug A and drug B for the entire treatment period? That's a great question. So the causal parameter asks, what's the difference if this population were prescribed and took the drug versus drug A versus drug B? So yes, if you define the causal parameter that way, then, and you do a per protocol analysis with that parameter in mind, then yes, that is the question of interest. If that's not your question of interest, though, if you want to say among subjects who can tolerate both drug A and drug B, what is that causal effect in that subpopulation, then you would have to formulate a different causal parameter, a different observed target statistical parameter that would now be, that difference in that subpopulation, and then you would estimate that. So it's perfectly fine to have a different question in mind. You can have many, multiple scientific questions, multiple causal parameters, The ITT parameter is a different causal parameter. And this one that you talk about here is also, I don't know how you would identify the subjects that could tolerate and have a potential outcome under both drugs. But if you could identify them, then we could certainly conceive of that as a causal parameter and try to estimate it from data.
Yeah, this is Mark. Yeah, so for example, I could imagine that you actually can identify over time if a patient is able to tolerate the treatment, like certain side effects starting to happen. And so in that case, you might be interested in a comparison of a rule, right? Which says, I'm going to start this drug with you, drug A, and I'm going to give it as long as you tolerate it. And once you have certain side effects, which tell me I have to stop it, then you stop. And then you still look at the outcome. So now you have two different interventions. They're called dynamic treatments, which try to keep the drug going, but is still looking at a time-dependent marker or whatever you measure to possibly change it. And that's then you get a comparison of two of these treatments, which try to stick to drug A and drug B, but still allow you to stop.
Oh, thank you.
Susan, this is Hannah. I just have one additional comment on this. So I think if the tolerance is of major interest in your study, then I would propose, I would suggest consider it as a, part of your intercurrent event, and then think about what might be the most relevant clinical question or what might be the most relevant target estimate first, and then define your causal parameter or target estimate accordingly.
Thanks, Hannah. We have another question from Yared. For the example trial you mentioned, can patients be censored intermittently, i.e. not show up at time point 2, but show up at time point 3? And how do you incorporate such data into the estimation process? Oh, sorry. And 2, can you give intuition on how patients who experience intercurrent events were accounted for in the analysis? It seems to me that your estimate of interest only looked at always takers versus never takers. Oh, okay. So 2 is easier to answer. It's more straightforward to answer. So basically, if a patient experiences an intercurrent event, and so their regime of interest, if I go back to that slide, just doesn't match the one that either one of our counterfactual regimes of interest, then they are right censored at that point. And then just it's internally, this happens in the it's part of the TMLE internal calculations, but essentially they just get the remaining people get upweighted, like with the inverse probability weight. That's what that G component does for us. It lets us say, okay, the 50-year-old woman who's had headaches for 2 years, et cetera, within that strata, if 1 out of 10 drop out, then the remaining that 1/10 gets distributed among the remaining people in that strata with the weight of the 1/10 of the woman who dropped out, let's say. Okay, now as far as being censored intermittently goes, if censored means you didn't show up, so we didn't collect your L's, then that's going to be a missing data problem. As long as you somehow were able to just stay on your drug, you made arrangements to get it mailed to you, or someone picked it up and dropped it off or something, then not getting the L's recorded, we can deal with as missing data, missing covariates. But if you mean they go on and off the drug for, let's say, 90 days, they just aren't taking it, then they're not following any regime of interest. And so we would just censor them at the point where they stop showing up. And again, they'll continue to contribute. They'll contribute observations observations that are following the regime will contribute to the analysis. So like it improves the variance that they stay in right up until the point where they are lost to follow-up or non-compliance. And then they also stay in, if you recall, a longitudinal TMLE kind of works backwards. And so at the very end, it marginalizes over the predicted counterfactual outcomes for everybody. And for this person would stay in there and be marginalized over, so that we still have the treatment effect in the population of interest. Is that clear? Or do you need a follow-up for that? Or Mark, do you want to add to that?
No, that's exactly right.
Okay.
I mean, but that's where, as Hannah also mentioned, we are getting then into these intercurrent events, which can inform dropout. And at the end of the day, you just have to specify what your intervention of interest is, and that in particular talks about what's the treatment regimen of interest, but also always intervening on not dropping out, so that we are getting the outcome, counterfactual outcome of interest. So that requires both an intervention on the treatment as well as making sure the person doesn't drop out. And then it's just like Susan said.
I don't see any more questions, so I will, I guess, leave it with that. Any last words from Hannah or Mark?
I have final concluding sort of remarks. So I just want to reiterate, well, obviously you can see the targeted learning framework and roadmap are also applicable to traditional clinical trial setting, although, the TMLE has been widely used in observational study space. But, this sort of training, highlighted it could also be used in clinical trial setting, and it's also consistent with ICH E9R1 estimate framework. And, one of the goals of having this training is, TMLE and super learning hasn't been utilized widely, and maybe it didn't even used in the regulatory setting, but you are probably aware that this has been widely used in outside the regulator world. So this is a relatively new technique for regulators and sponsors, but we expect to see more submissions using this TMLE and super learning down the road. So this training and the upcoming training is about how we, what might be the review issues once we actually see the real submission, the proposed to use TMLE, and what should be our focus in reviewing SAP. So hopefully this could be helpful for our future review.
Thank you, Hannah and Mark, and thank you everybody for joining us today.